Hello, welcome to this mini lecture on the approach to dyspnea, which specifically cater for undergraduate medical students in their internal medicine rotations. We have three learning outcomes. Number one is to describe a logical and practical approach to assessing patients with breathlessness and list the differential diagnosis of patients with breathlessness and describe the overview of the management, specifically of bronchial asthma, chronic obstructive pulmonary disease, and heart failure. Before we start our lecture, it would be very helpful to recall your prior knowledge on the regulations of breathing, specifically the respiratory centers and associated triggering stimuli of respirations. Some basic considerations when approaching patients with dyspnea or shortness of breath is to recognize the medical emergencies and the context of the patient's complaint, consider underlying etiologies or causes, perform a baseline examinations to guide the formulations of action plan and communicate it with patients and colleagues. Here are some of the medical emergencies that will let patients presented with dyspnea. One is the upper airway obstructions, severe pneumonia, severe obstructive lung disease, massive effusions or tension pneumothorax, massive pulmonary embolism, acute coronary syndromes, heart failure, and cardiac tamponade. As you can see, patients with dyspnea doesn't necessarily always mean a lung disease. It can be a cardiac disease as well. Other differential diagnoses that you want to consider in the respiratory symptoms for patients with dyspnea are bronchial asthma, chronic obstructive pulmonary disease, bronchiectasis, pneumonia of various causes, interstitial lung disease, pleural effusions, and pulmonary embolism. For the cardiovascular system, patients who presented with dyspnea could be caused by acute coronary syndrome, heart failure, or arrhythmia. Other causes of patients presented with dyspnea can be severe anemia, gastroesophageal reflux, anxiety or panic attack. So we'll now delve deeper on what does it mean by dyspnea or breathlessness. It is defined as the subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. Here, what is important is the word subjective. So means patient's experience matter. It can mean increased work of breathing, tightness, or air hunger. So your history should take into account patient's story. Find out the onset and durations of the breathlessness. It can be minutes, hours, days, weeks, or months. Associated symptoms, background events, limitations of activities which require objective assessment, previous medical problems, home conditions, and specifically for respiratory problem, you need to ask about occupation, smoking, and history of allergy. So to objectively quantify the severity of breathlessness, we can use Modified Medical Research Council scale, MMRC, or New York Heart Association scale. MMRC are usually used for patients with chronic obstructive pulmonary disease, and New York Heart Association's classifications is usually used for patients with heart failure. Now I shall pause a few seconds for you to look at the scale in more detail. The examinations of the patients presented with dyspnea or breathlessness should begin with checking the vital signs. Look at the heart rate, blood pressure, respiratory rate, temperature, and pain. Seek for specifically the signs of respiratory distress, such as the use of accessory muscles, tachypnea, unable to complete one sentences, or hypoxia. Look for signs of heart failure, such as raised jugular venous pressure, peripheral edema, crepitations basal, and reduced breath sound. In the periphery, look for clubbing, cyanosis, Taylor, raised jugular venous pressure. In the chest, look for scar or deformity, tracheal deviations, percussion to look for resonant or dullness. Listen to the breath sound and whether there's added bronchi or crepitations. In the precordial, listen for heart sound and murmur. The investigations of a patient with breathlessness depends on the history and examinations. Some of the bedside tests that we can perform are oxygen saturations, peak flow meter, electrocardiogram, ECG, arterial blood gas to look for hypoxemia, hypercarbia, respiratory alkalosis from hyperventilations. Some of the basic imaging would be chest radiograph, and the laboratory blood test could be blood count to look for anemia, neutrophilia, eosinophilia, renal profile, cardiac biomarker, C-reactive protein to look for systemic inflammation, D-dimer will be raised in venous thromboembolism, and NT-proBNP, which is a marker of heart failure. So moving forward, I'll be sharing 3 case reports published in academic journal to demonstrate the logical approach to patients with bronchial asthma, chronic obstructive pulmonary disease, and heart failure. Some of this disease will present typically with breathlessness, and some will be having atypical presentations. The first case will be a bronchial asthma published by Alkan et al. The author described a 30-year-old female who presented with shortness of breath, subjective fever, and cough for 2-day durations. The past medical history is significant for childhood asthma on when-needed salbutamol inhaler. The triggering factor for the asthma is dust and upper respiratory tract infections. She has history of drug-induced hypersensitivity during asthma exacerbation in the past. However, the exact drug is not known. This time round, on examination, she was conscious, but tachypnea and hypoxia, and she has tachycardia with a normal blood pressure. There's accessory muscle use and wheezing. So moving next, we will look at the investigations and the initial management of this lady. The full blood count was normal, there's no eosinophilia. The team took a venous blood gas, which showed metabolic acidosis, and a chest radiograph shows there's hyperinflated lungs. So putting all this together, the patient is having moderate asthma secondary to upper respiratory tract infections. The team has given the patients short-acting beta-agonist plus a short-acting muscarinic antagonist nebulizer, and as a standard of care, intravenous corticosteroid was given. However, the patient's conditions worsened after just a few minutes. She became anxious, developed chest tightness, severe shortness of breath and fatigue. She became hypotensive, more tachypnic and hypoxia, and there's tachycardia. Then they came with a second diagnosis of anaphylaxis reaction secondary to steroids, which could explain the previous drug hypersensitivities in her previous exacerbations of asthma. Now, this is a rare occasion of steroid-induced anaphylactic shock in the patients with bronchial asthma exacerbations, and this complicates the care as the steroid use is considered standard of care in patients with asthma exacerbations. Specific management for patients with anaphylaxis is adrenaline. With regards to bronchial asthma, we would usually provide ventilatory support, corticosteroids, bronchial dilator, treat infections if there's any, and we will provide asthma action plan upon discharge. Now, case 2 is on chronic obstructive pulmonary disease, and this case was reported by Ziligiani and colleagues from the United Kingdom and in the context of their primary care practice. They described a 63-year-old female with 80 PET years of smoking history. She developed severe dyspnoea without tachycardia or chest pain 30 minutes into air flight. The past medical history was significant for hypertension, moderate COPD, mild heart failure, severe osteoarthritis in the left knee. On examinations, she was hypoxia requiring 2 liters of nasal prong oxygen in flight, which condition improved after she landed. After she landed to the ground, several investigations was performed to find out the cause of the hypoxia by the cardiologists and respiratory physicians. The ECG and echocardiography show no significant abnormalities to explain the hypoxia. The spirometry shows the fractions expirations of the volume in the first second was 60% predicted, and the FVV1 over FVC is 0.65 obstructive picture. Ideally, a hypobaric inhalation test will be performed to predict future hypoxia event in flight. This is because at a higher altitude, like in those in airplane, the partial pressure of oxygen would reduce, and in a normal person, the compensatory response is to be hyperventilating. However, this compensatory response in patients with COPD is inadequate to support the oxygen need. That's why the patients develop hypoxia. Now, the specific management for any patients with chronic obstructive pulmonary disease is to provide a bronchodilator, advise for smoking cessations, provide pulmonary rehabilitations, and vaccination. We would provide oxygen supplementations if there's evidence of severe hypoxia and evidence of right heart failure. Now, the last case is on heart failure, and the author Habib et al. Is describing atypical presentations of heart failure with acalculous cholecystitis. The authors describe a 69-year-old man presented with fever, chills, generalized body aches, right upper quadrant, abdominal pain, nausea and vomiting for 2 days. The past medical history is significant for type 2 diabetes mellitus and hypertension. On examinations, the patient is unwell, jaundice, and is tachypneic, afebrile, blood pressure is borderline low. There's positive hepatojugular reflux. On the abdomen examinations, the right upper quadrant was tender and there's shifting downwards. Chest examinations show a decreased breath sound at the lung bases without crepitations. Several investigations was performed on these patients. His liver function test shows derangement with raised total bilirubin. He has raised inflammatory markers with CRP of 18.7, procalcitonin of 3.34. The renal profile shows that the patient is having an acute kidney injury. Abdominal ultrasound revealed moderate ascites, confirmed the clinical findings of shifting downwards, congestive hepatopathy, and a thickened edematous gallbladder wall without a gallstone. So the team came with a diagnosis of acalculous cholecystitis. So given the initial diagnosis of acalculous cholecystitis, he was treated with intravenous antibiotics and intravenous fluid, which he subsequently deteriorated and became hypotensive. The following investigations of NT-proBNP shows 16,000, which is raised, and the echocardiography show a biventricular and biatrial dilatations, a LVEF of 25%, which is low, with severe hypokinesia, a grade 3 diastolic dysfunction, and a severe tricuspid regurgitation. Putting all this together, the second diagnosis was a biventricular cardiogenic shock and a secondary multisystem organ failure with encephalopathy, ischemic, congestive hepatopathy, and cardiorenal syndrome. So this case highlights the atypical presentations of the heart failure, which usually patients came with shortness of breath, autopnea, and paroxysmal nocturnal dyspnea. For any case of heart failure, we should treat the cause, which in this patient, he is found to be having triple vessel disease from a coronary angiogram, and we should offer a coronary intervention to such patients. The specific management for patients with heart failure, especially during acute decompensations, is diuresis for symptom control, organ support, and upon discharge, we should initiate guideline-directed medical therapy. So here are 2 references for your further readings on the approach to patients with breathlessness. Now we have come to the end on the mini lecture on the approach to dyspnea. We have covered the presenting symptoms, examination findings, key investigations, and principle of management for patients specifically of bronchial asthma, chronic obstructive pulmonary disease, and heart failure. Any questions and answers, please leave in the comment section, and I hope to see you again. Bye-bye.